Okay. And okay, so updates from the global symposium. So so basically I'm just going to start with where I had planned to start, and then we can um, fill in, Alexander, with what you guys discussed. So um, our first part was the vocabulary-a-thon. And, this was hopefully supposed to be a place where we could kind of look at what we have to do as a community, not just what our the survey interests are. So I kind of set up some goals for us in terms of what our solutions should be able to do. So we don't want to conflict with current solutions, right? So we know that the OMOP is a complex, very dynamic entity with a lot of best practices and vocabularies and rules. And we want to come up with solutions that are not going to conflict with what we're doing for clinical data. It doesn't mean we can't add new things, but we just don't want to go in contrast to something that's already a policy. Um, while I think it's helpful that we have a lot of use cases as we build out our solutions, we don't want them to be use case specific. We want them to apply more generally to surveys. And then I think we also want to take into consideration, what do we ultimately want to do with these data? So what's and this is kind of comes from another slide too, but what's our motivation for mapping to OMOP in the first place? Is it to use the tools? Is it to harmonize? Is it both? Because I think different, from what I've heard from different people, they're kind of different motivations for doing this. So one of the other things we really need to refine too, as we're working more with the psychiatry group and more of their psychometrics and things that behave a little bit differently than surveys, is kind of develop our definition. And yeah, Ben?
Yeah, I was going to wait till you finish talking about the slides. I mean, this is something that I have a lot to discuss because of some recent work that's been happening with the MCOs and Medicaid.
Great.
So I want to just let you know that I've got a few when we get to that.
Yes. Yeah.
Right.
And this is not the definition we ended with. This is just what we started with. So I think this is still I don't think we can begin to find solutions until we finish defining the problem. And so
I think
that would be
the main point was that the treatment of patient-reported outcomes or patient-reported information, patient-generated health data is somewhat different from the use of a standardized instrument, like a measurement of that. And this came about because on a behavioral health TEP that I am on, there was a lot of concerns in the clinicians on the TEP that the PROMs themselves were actually equivalent to a diagnosis when they're not, and that was a big piece of confusion that we need to make sure in our definition. We're talking about measurements. We're talking about, if we're talking about PROMs, we're talking about measurements. If we're talking about pros, we're talking about something else perhaps, or we're talking about a survey or a computer adaptive survey or something like that. There's kind of different, we got to try and accommodate as much of that in the definition as possible. So
yeah. No, that's appreciated. And there's actually a paper that Piper started that I was going to segue to, that I think it has some nice definitions for us in terms of this is like the overarching broadest class, and then these are some of the subclasses, and like you said, getting to the use case of what these are actually used for, because psychometrics are used diagnostically, surveys aren't, or if you use survey data, lots of times it's also in combination with EHR data or genetic data to come up with a risk score, that kind of
this is important when we're talking about the documentation stage, because a lot of PROMs now currently are not being documented. Their use is not being documented using like an assessment or a measurement terminology. They're being used some kind of pre-coordinated ICD or some kind of HCPCS code that just obscures a lot of the information, because that's sort of what they were told to do. That was part of the the claims focus thing. And so I think there's going to also be a transition as we get more specific on the real world side versus how we sort of see this in the OMOP data sets. There may be a transition period, what do you want to call it? Because a lot of them now are shifting over to using like Loink and things like that for the assessments and the measurements, and away from the HCPCS and the ICD, whatever you want to call it, version. So there's going to be kind of a blend of God knows what out there in the real world data sets.
And I think that's kind of a nice segue to this next one. I think this is why we really we need to come up with use cases under each of the sort of classes of survey. You know, so proms versus a pros versus psychometrics and whatever other acronyms we can come up with, because they are going to have, I don't know, from my perspective, in order to start thinking about broad solutions, I need to see what the individual problems are and then what could solve something like across the board and what requires something unique. And so we had some additional people that I need to reach back out to who joined us um, at the Global Symposium who also had use cases that I think would be helpful to the group, but I wasn't able at the time to do any follow up on that. But that's really something like Ben, you have specific use cases that you just gave. Our cohort studies have, do things in common that's a little bit different. So, when we get patient reported outcomes or measures, we're actively acting for it as part of a study, and it's not going into claims or being coded as something in a medical record, whereas something being done in a clinical setting would be.
Right. Right.
So I think it would be helpful to, you know respectfully, I'm asking everyone on the call to kind of come up with and try to answer these types, like what is your, what's your survey um, relative to how you're thinking about analyzing the data. Does the mapping is there a mapping type that's more favorable or useful? And like I just said before, it's also really important to think about, like, we all know this is going to be a lot of work, both once we have some, both developing sort of our standards, but also, getting people to want to apply them, right? There's no point doing it if nobody wants to use it. So, trying to figure out, why do we even want to be an OMOP? Do we want to use tools? Do we want to harmonize? Do we want to do both? Do you want to combine survey data with EHR data or claims data? So I think it's important that the use cases think about that. So that's one thing that might be nice to do. We've got 2 weeks before we meet again. So if everyone in the call could work on like a use case, and then I'll reach out to the group and ask them to do that, I think that will also help us kind of start prioritizing what, you know, what needs to be done and getting a better idea of these bits and pieces. Because, yeah.
Yeah, to the MCOs and to others who will listen is the importance of a name value pairing of the data. When you have a question or an instrument completed, that the specific code that identifies the name of that instrument is important as the value of whatever that questionnaire response number is, if you will, the score. And we're really trying to push that level of granularity in the documentation of this data, such that it can be measured once and used for multiple different use cases, multiple purposes.
Right.
Because right now it's all very bespoke and a very singular use case siloed kind of aspect, and it doesn't help anybody. And so that's what we're sort of shouting from the rooftops right now, is the importance of a very granular name value pairing for each time these instruments are administered, such that you can use them for monitoring, you can use them for assessment, you can use them for clinical decision making, care plans, you name it.
Yeah, I 100% agree with that. I think that the table has to have columns. Like there has to be a way to put the name of the survey instrument, the version number, the question number, the question, the answer. Like they won't all be used for all the times, but if we don't do that, we're going to be right back here as soon as someone says, but what about? And I realize we can't solve for everything all at once. Right. But some of those things are obvious. Like the kinds of metadata that survey researchers always use should be there.
Yeah, and then I agree, and that's helpful. Like you said, we can't solve everything, but I think if we end up with a list of what we need to solve and then triage that list, then we can start getting somewhere. And I think getting these use cases together would help. And so let me go back I'm going to go ahead and stop here because the rest was more kind of the goals for the vocabulary-thon, which were harder to do, having not been there. So I'm going to pause here, and then Alex and Piper, from your perspectives, is there anything you want to add to sort of the conversations we had as part of it? I do, Piper, have your brainstorming sheet and added to that. So a lot of what we spent time on was trying to figure out this definition and if psychometrics were going to be part of it because of the different ways in which they were analyzed. But yeah, I want to see what you two wanted to say before we moved on to looking at the definitions. And then shortly after the Global Symposium, Piper went to a SNOMED meeting, and they are also working on expanding terms for surveys. So I thought Piper could update us, give us a summary of what they worked on there.
Alexander, did you have anything you wanted to add?
Well, there is only one thing I like to talk about, and that is a definition.
Mm-hmm.
But in my opinion, we actually need to have two definitions because there might be the broad and narrow one. But Piper, I think that you've put in place a wonderful document after the vocabulary, so maybe you can guide us through that and in what happened on the SNOMED meeting.
Yeah, sure. Okay. So, Nicole, I'll just say everybody does this. It's really funny. SNOMED has no W in it.
Oh,
That's like, it's so classic for people to put the W in. But yeah,
I should
no
know
W
better
in
than it would
SNOMED.
actually be totally spelt the way it sounds, right? Like
Right.
acronyms sort of spell like they sound, but not totally. All right, all better.
Okay, and so Alex, which are you talking about the document where we started to outline sort of the distinction, like defining what an assessment is or an instrument is, or which?
This is the one I had, which was the one you sent me, and then I put in my 2 cents and then tried to come up with a definition. And I had put this in here about the qualitative measures, but I also think by the time we finish some of our conversations, there's still a way to fit this in there. And I don't know, Piper, if you would want to share the paper you started drafting. I was reading that yesterday and had some comments, but I really do like how I think it's a nice way of, this is the overarching class and then these are the subclasses. And that might be a better way to, I've been trying to come up with like an easy paragraph definition. And, maybe this could be the summary definition, but I think the way you outline it in the paper is very helpful.
Okay, let me see if I can pull that up. Hang on. And you know what? There is CDESC, and I don't remember which draft you're looking at, Nicole, but CDESC has an interesting definition, and I'd like to incorporate their definition. I think we should look at the various definitions that are out there. Okay, so I'm trying.
There's not a version number on mine, so I'm not sure if the one I have is different from your most current version.
Okay.
You sent this to me during the furlough, so in October.
Okay. And let's see, I don't know, have I worked on it? Okay, so we are calling this our, what's the title of that one?
Computerized representation of assessment instruments.
Yes. Landscape analysis of representation, computerized, yes. Okay, hang on. Bennett. What's that? And, I want to sort of open it up too to other folks on the call. Alexander, I know you for one, for sure might be interested, but anyone that's interested in collaborating on this paper, I think it would be great. The more Maybe the more the merrier, maybe the more difficult. I don't know. It's hard to say. Okay, so okay, so put these in. All right. Reorient here. Okay, so yeah, so the evolving landscape of structured and computable representations. I don't know what we'll call it. All right, let's see if I can share this. All right, screen. Okay. So I guess let's look at this in simple view. Simple, no markup. Yeah, no markup. Okay. So yeah, so basically kind of just laying it out, right? I'm using this standardized assessment instrument as sort of that top level thing, but the use of these instruments, ubiquitous in healthcare, increasing number of organizations, products, initiatives, investing substantial resources, blah, blah, blah. And so then we said the objective of this study is to provide a comprehensive overview of these technologies, right? The SAI related technologies and initiatives, and present a framework for streamlining existing efforts through greater cross-organizational collaboration. And so essentially, kind of a landscape analysis. So we kind of introduced background and significance. And I think we want to just bring in all the different terms that are used right across the enterprise. So people talk about pros, proms, ClinRos, POAs or COAs, right? Psychometric instruments. And then, all the generic terms, right? This, essentially these instruments play a critical role in measurement-based care and knowledge discovery. They comprise a broad yet poorly defined class of things variously known as instruments. So these are kind of all the words that we use. But then, folks have come out with these more specific ones. All right. And then so data and methods, looking at various definitions of these assessments, identifiers, and then semantic models. And then here's sort of the starting point. And I think we need to think about what the best way to structure this table might be. I kind of started out with just throwing stuff in, right? So this isn't really systematic, and I'm sort of thinking that the structure of this table will evolve, right, as we sort of iterate through this and we start to identify kind of ways in which they're different. But we can talk about the initiatives, the descriptions, maybe, sponsors, and then trying to get a count of instruments. And I kind of, again, okay, this SDCI.
Are you focused on open source instruments, or are you going to try and include everything under the sun?
Wait, say that again.
Are you focused mostly on open source or open access instruments, or are you trying to really include everything? I mean, there's a whole ton of proprietary,
Yep.
IP instruments out there too. So
yep. So PsychTest has like 75,000, right? So clearly we're gonna do an initial, like, here's the landscape of organizations that have, whether it is that they're developing instruments or just curating them, right? So you look at something like PsychTest, Eric, there's also Mini Mental Yearbook. There's a couple of them. Oh, and HAPPY, which is Health and Psychometric or Psychosocial Instruments. And these are databases, right? So these just kind of, there's curators, right? So that's a little different, right? These curated collections. And when we get to things like adding them to Odyssey or SNOMED or Loink, really the only instruments that are worth putting in clinical terminology are instruments that are really heavily utilized, right, in healthcare. And so that's the secondary study or, that we need to do is we need to sort of, and the psychiatry working group has started to do this, and that's to say, of this massive universe of literally tens of thousands of psychometrically validated assessment instruments, which ones do people actually use in research and care? So.
And who are you thinking of asking about that? Like, are we thinking of a survey? Is it just common knowledge which ones are user care, or that it would be in EHRs?
Yeah, so that I think is, I think that's a multi-pronged approach. So the first thing would be look at real world data, right? That's probably the source of truth. Who is capturing this in their EHR? So, and the psychiatry working group has already started to do that. So like I pulled from our system, we have, I think, up to over 500, like close to 300 assessment instruments, but that's counting versions, right? So you've got a whole bunch of, you've got 3 versions of the Beck Depression Inventory. You've got multiple version of the AIMS, which is the abnormal movement scale. So you've got the short version, the long version. There's literally 10 versions of the geriatric depression scale. And then, of course, you have all the language translations. So a lot. But volume, go ahead.
I was going to say, one of the other methods you might deploy is working backwards from the terminologies. I mean, if they have been modeled in terminology, they're probably going to be you can then determine their usage, because obviously the instrument's been modeled using Loink, or it's been using, mentioned in SNOMED, because someone's gone through the trouble of actually requesting the code and
yes,
or the
yes.
Right.
Yes, that is the other. So there's one, what's been curated, right? Either added to clinical terminologies or curated in these systems. Curation probably isn't a good one, but things that are actually being used. And we did do the, when we pulled our real world data, our analysis was real world data, Loink, what was in Loink and what was in SNOMED, and then like you said, what's in Loink and SNOMED, but not in any real world data. I think that Loink is going to be, SNOMED just has a lot of historical content that came from a lot of different places. So there might be a way for us to look at what's been added like in the last 10 years, but they've got stuff that I had never heard of, and then I went to look it up, and it was an assessment that was developed so far back they were still debating whether there was whether depressive disorder actually existed in children. So it was
Loink is more actively curated. It's also the terminology that's being pushed by CMS and CDC for standardized collection of proms. So, they're behind it, pushing it. They, you probably see a better curation of, in Loink than you will in SNOMED. SNOMED's just kind of like a kitchen sink of everything.
Yeah. And we met. So I guess the other piece maybe to talk about is, so we since the Odyssey Global Symposium, we've had the SNOMED International meeting in Belgium. That was like late October. And then just last week, the AMIA meeting. And so I spent quite a bit of time with Isa. I don't know if folks know Isa, but she would be the person that we would be working most closely with to add content. And so she and I have been working together to try to fast track content into Loink. Then we also met at the SNOMED International meeting in Belgium. We had an entire session devoted to assessment instruments. And in that meeting, we had not just the SNOMED folks, but we had Isa, Stan, and Rob McClure, and those are the three kind of key folks that we'll be working with, around content for Loink. So I don't know, Nicole, I don't know if I told you this even, but Loink is working to develop a new semantic model for assessment, for surveys. You're on mute. I think you and I talked after that meeting, didn't we?
You did. Yeah, you mentioned that.
Okay.
Yeah.
Yeah. So Loink is working on a new assessment or a new model for their survey class. The discussion we had at SNOMED was multifold. So we had a discussion then, and then we had a couple of follow-up discussions on the phone. And the primary, so we requested a couple of changes to SNOMED. The subsumption, meaning how, right now, the way that the ISA relationship is, where a subscale is a subtype of the parent scale, isn't quite right, because it's not a subtype of it, it's actually a subscale. And it looks okay in the browser, but once you start defining attributes for the assessment model, it doesn't subsume correctly. So SNOMED does have what they said they are going to do is they are going to implement the new part of relationship that will take care of that. So I don't know when that is going to happen, but they're aware of that. The other thing we talked about is that we wanted a new, and so there's a couple of issues with the way the content exists in the assessment hierarchy, which is just a matter of cleaning it up. There's stuff like where a second version of an instrument is modeled as a subtype of the original instrument, and that's not what we want. And then as far as the scores go, we talked about, we requested a new attribute for specifying the instrument. We wanted an attribute called using assessment instrument, and they said no. And so now and what they did is they extended the technique attributes. So they're saying just use technique, and there's problems with that, but there is a defining attribute called using device. And I know we're getting in the weeds here, so maybe we don't even want to go this far into the weeds, but in any case, we are working on finding ways to model assessments correctly and fully. And the other thing Loink said is that they will be able to add all the questions, so we can code the questions. What they can't, regardless of whether you have copyright release or not, they will be able to add the questions. What they won't be able to do without a copyright or without permission is to model the questions as being part of a specific survey, right? So what does that buy us? That buys us the ability at least to have a code for the questions and a code for the answers, as well as a code for the assessment. But what we won't have in Loink is that relationship that says these questions are part of these assessments until we get copyright release, or that won't be an issue if it's an open source instrument.
If they're giving codes for the name of the assessment, though, I would think the connection could be made on the OMOP end if needed.
100%. 100%.
I think Loink is worried about intellectual property rights, and they're very strict on that.
That's fair. I don't blame them.
We got around that in the measure space just by only requesting that the total score for that named instrument be modeled in Loink, so that we could still have them in there, but not like they wouldn't allow us to model each question because that violates their property, whatever it is, for that each question within that instrument. But that's still a workaround because then you can't use any of the individual questions if you want to. So it,
Well, you
it's a
can.
conflict
So,
there.
so previously, so this is a big change because they talked to their legal team, and the legal team said they can't copyright individual questions. They can copyright the instrument as a whole or the assessment as a whole, saying these questions are part of this assessment. So again, the good news is to be able to have a code for the individual questions is huge, right?
Yeah,
To have a code
agreed.
for the questions and the answers. And then of course for the surveys, you guys really need to link that to here's the finding, right? Here's, do you have a family history of, or do you have has a doctor ever told you you have cancer? You want to link that to cancer or no cancer.
Well, the absence of cancer is currently a very challenging thing to discover in OMAP. It doesn't really exist as a concept.
What about the stuff the oncology work group is doing? I thought there was an expansion or something for that. Is there not? I say this not having played with it. I just know of the existence of the work group.
I hope that's true. You are way more up on well the work groups than I am. But I know we've really struggled with like the absence of a condition not being.
Oh, absence. Yeah, anything
Right?
negative
Right.
is definitely hard. And I don't know if
Yeah.
that's something that worked on it, but it's definitely something in our sort of list of things we need. The being able to map a lack of something is necessary. Like within
Yeah.
the survey area,
Absent.
we can't
Yeah.
treat the nulls the way you do in EHR.
Right.
And you said
Exactly.
too, yeah.
If
And
someone
it's
affirmatively
relevant to the
says no to something, that's very different from not having a record of that
record.
at all.
Yeah.
Yeah. And then of course. And the other piece is if we do map something like they say they have a family history or they say they have a personal history of a condition, then we've talked about this in this group before, that we also need to preserve a record of that being self-report as opposed to directly coming to us as an EHR, even though we'll map to exactly the same condition.
Yeah, and that's where having this is survey or self-reported versus EHR type flag will be important. And I imagine this is just something you're doing with all of us. We're doing it with Connect. Like part of it, we want to see what the correspondence is between what they're self-reporting and what they're seeing, what we're seeing in their EHR.
Exactly.
Yeah. All right. So I'm glad it's helpful, Piper, to have you, and everyone else is sort of dipping, you too, Ben, in other areas to kind of bring these in. And so what I'm thinking as far as the definition goes, because I think that was the next item on my list. Piper, are you still available to meet at 4 today, or for my time through your time?
I actually am not.
Okay. So I think, so in the absence of that, so I think what I'll do is I'm going to take the working definition from the Global Symposium, which is that sheet I showed really quickly, and the paper, and kind of try to come up with a high level definition and then this, sort of subclasses definitions. I'm going to share that out with the group before our next meeting. And then I'm also going to send, obviously I've already asked you guys for this, but I'll send it to the whole group, the request for the use cases. And I think if we could have those done I'll actually try to ask for them a few days before our next meeting so we can collate it. And then that would be really nice to kind of use as the basis of starting to think about what our priorities and our OKRs are for 2026, which I can't believe is right around the corner. Of course, missing a month of work will do that. But I think it's not, I think this is a good time to actually, because we're a young group, we usually haven't started our OKRs until like January or February because of the holidays. But I think we're in a position to start them for this year and really set what our priorities are, and even flesh out a little bit of what those steps are for each of those priorities, and get 2026 off to a productive start. So let's see. So we do have 20 minutes left, so maybe I jumped the gun a little bit, but this has been a good discussion. Is there anything else we should be discussing or thinking about, that information we need to bring in order to make some decisions or set priorities that we haven't talked about yet?
I was just going to ask, Ben, can you talk a little bit about the work that you're doing right now around assessments or surveys?
Yeah, sure. I mean, most of it now, again, is really trying to align the level of granularity in the data that across the different standards. So, you know, for quality measures, we have a lot of new prompts in these new core sets that are being collected by MCOs and other people, and they're using pre-coordinated codes to do that, which are not helping anybody. And so we're preaching, again, the use of like a name value pairing at the level of granularity for each question or each instrument, depending on what you're using, such that you can collect once, you know, and use for many, many different opportunities. That is also, we're also, because screening for depression and suicidality are also kind of a high priority, we're suggesting that the reason we're suggesting at the question level you want that name value pairing is because, like on the PHQ-9, you can use that for screening for depression, for monitoring depression symptoms, but also if you use the responses from question 9 of a 1, 2, or 3, you can also sort of theoretically screen for suicidality or suicide ideation. So we're trying to sort of promote this idea of collecting at a certain level of information that you can then you know, use for many, many different purposes, no matter what you're trying to do with it, and reducing the number of questions or number of instruments you need to then administer to folks, kind of thing. So, and also, and again, the other piece is that we're really trying to promote this idea that a PROM is not equivalent to an observation or diagnosis. A PROM is a measurement like a blood pressure. So you have a systolic blood pressure measurement that you take, you know, multiple times. You have a PHQ-9 total score reported, and a value that you take multiple times over a course of period, right? So that's kind of what we're trying to promote, that, because a lot of the physicians on the measurement expert panels for ECQMs had a lot, were, especially in the behavioral health space, were really concerned about these PROMs being used for screening for depression and suicidality, because they were concerned that these were going to be treated as either diagnoses or an observation of a finding of something that really all they're supposed to do is trigger some kind of follow-up or some kind of further investigation, not, and so again, just trying to really support this idea of what these are and how they should be used and the level of granularity of information you need is kind of where we are right now. I sort of gave up on the cross standards harmonization of these different things because I realized there was so much mayhem out there in the so I'm hoping to come back to that soon, but for right now it's kind of on hold.
Yeah. Ben, who's the we? Is this the group you work for, or is there a work group and other work groups you're working with Odyssey?
Yeah, so I work for a QuinnQIO for Region 2 right now, for CMS Region 2. My organization also has a huge managed care department, which supports a number of state Medicaid agencies and DHS agencies with the Medicaid core set reporting. They have their own quality measure state report cards that they do, and so on and so forth. And they have a whole host of different state requirements that they need. So I'm kind of have one foot in both camps.
Okay.
I'm working on the CMS side for DQMs, and also and you know, doing the QuinnQIO stuff, but I'm also supporting all the managed care organizations in the various states because that's what we do. You know, we support all. We do a lot of data collection and a lot of measure calculation for, you know, Medicaid core set reporting, et cetera, et cetera.
So you work primarily in the measurement space?
I am a quality measure person through and through.
Okay.
I spent 17 years at NCQA in their quality measurement research group. So doing, you know, all the HEDIS all the time, ECQMs, DQMs, you name it. Yeah, that's me.
So, interesting you mentioned that because we were talking about where do we find out which instruments are important to have represented. And we talked about EHRs, what's in the standards, but we also talked about what's in quality measures and what's, if anything, in clinical practice guidelines, right? Because you'd think if they're in the measures, typically what's in the measure drives what goes into the guideline, or probably the other way around, right? What's in the measure?
I always joke that you put it in a quality, you put a data element or a data structure in a quality measure, suddenly people pay attention to it, right? That's a good way to get people to pay attention to things. Right now in the measurement space, at least in the national measurement space, proms are becoming increasingly significant, and that's a great first step. But also, there's a patient-centered outcomes initiative, which is looking at patient goal setting and care plan arrangement, if you will. And they are not actually focused on proms with that, unlike the social needs screening and the depression screening and other things. They're actually looking to kind of create goal domains, which might be structured, having these questions that are asked, or are you setting goals around the responses to these questions kind of thing, which is really complicated.
Okay. Interesting. Okay, so definitely more survey type. So, and then can I just ask, when you use the word pros and proms, are you referring typically to something like the PHQ-9, like a psychometrically validated assessment, or could it sometimes just be a survey?
When I say prom, I mean the instrument itself. That's the collection of those questions that has been validated to do a specific task, whether it's a functional status or it's a screening or a management assessment instrument. So I start with PGHD, which is kind of everything under the sun. If you go to the next bubble down, there's the pros, which is kind of all the patient-reported information, and then the next bubble down is the proms. And then the smaller bubble from that is the pro PMs, which are the measures that use proms to assess, healthcare quality. So when I say prom, I mean those instruments like PHQ-9, like the geriatric depression scale, the actual instrument itself. That's the collection of things.
Things that are actually intending to measure some construct like blood pressure, like a blood pressure measures blood pressure.
The M at the end is the key. It's the measurement piece that it creates essentially a measurement that gives you a value that means something to some clinician if you use that information as part of your clinical decision making or your care decision making, right? I try and say a prom is like a blood pressure, like it's a measurement and it gives you a value that is meaningful if you put it in context of something else, but alone it does not do anything, but if you go out in the pro space, like this person-centered outcomes project, the pros get a little wonky there because sometimes they're standardized questions, sometimes they're not standardized questions, sometimes the goals are focused on things that are not currently standardized as modeled as a question or as a goal, if you will. So it's a little gray there, but I like to just focus on the proms for now because there's still a lot to be consolidated and clarified in that space. Before we get into really, the fun, complex space where you have, 750,000 different possibilities.
Right.
Yeah.
So let me ask you a question with the proms.
Yes.
They're not used to they don't come up with a diagnosis, right? They're used to measure something. Right. But in that space, do you link the score to the thing that's being measured? So for example, do you say PHQ-9 measures depression or Columbia suicide risk measures? Go ahead.
Right. So here's how it works in the digital quality measure for depression screening and follow-up. I'll just use that as my favorite example. And I can follow up with another example after that. So currently the measure has a list of proms that are age appropriate for any screening purpose that they, for adolescents, they have the list of adolescent instruments. For the adult, they have the adult instruments. It includes PHQ-2, PHQ-9, and a whole bunch of others I can't list off the top of my head right now. The measure looks for the presence of that LOINC code that defines that instrument administration with the date of service or whatever it is, the event, right? And the score. And the measure developer has actually set a threshold for each of those scores. It's not the bottom line. Like for depression in the PHQ-9, we're looking for moderate to severe depression finding or indication, if you will. So we're not like overloading the behavioral healthcare system with referrals for depression for people who just are having a questionable day and may have scored a 5 on the PHQ-9, for example. So the quality measure actually has all those thresholds built into the logic of the measure. And so if, for example, you score positive on the PHQ-2, the measure puts you in the second phase of the measure, which says if you have a positive finding on the PHQ-2, you need some kind of follow-up. Appropriate follow-up for that is an immediate administration of the PHQ-9, which completes the rest of the questions to then say, okay, do you need something else because you're now scoring positive on the PHQ-9 versus the PHQ-2. And the measure does all that automatically. It's all built into the measure logic. So if you score positive on each individual instrument, you are then kicked into the denominator of the second part of the measure, which says if you have a positive finding, have you had some kind of follow-up? And then the follow-up is a whole kitchen sink of possibilities relevant to that particular screening instrument.
You put these measures in the VSAC?
Well, yes and no. The instrument administration is actually, there are direct reference codes right in the measure logic. So for each instrument, there is a whole, like it's in CQL right now, clinical quality language, where the code is actually direct reference code actually in the measure logic. So the LOINC code for PHQ-9 total score reported, which is a very specific LOINC code, is actually in the measure logic itself. And then it says, there's basically a simple if-then pattern that says, if the total score reported for this instrument, PHQ-9, is above, I don't know what it is right now, it's 7 or 8, I think, then, put them in the denominator.
To do the next step.
Right,
Gotcha.
next step. So,
Okay.
it's a pretty, it's pretty basic if-then, but it's a lot of logical patterning because it gets very complicated when you try and get a computer to do it logically. I mean, a human can do it in 3 seconds, a computer can do it faster, but you have to have a lot of instructions that go with it.
Quick question for you, because I think this is a powerful use case, right?
Mm-hmm.
There's no longer, there used to be like the measurement clearinghouse and the guideline clearinghouse that no
Right.
longer exist.
Yep.
What is the best way to access the measures, these measures, the actual CQLs? Or what are they called?
For a lot of these, you can't, unfortunately. So
Okay.
CMS, the ECQMs, which are still not up to date yet with these new measurement constructs, are available on the ECQM Resource Center from CMS. So a lot of measures are available there. They won't give you that detailed logical pattern, though, because a lot of that is proprietary to Measure Steward, like NCQA, or to Joint Commission and those kind of things. So
yeah,
you kind of run into some of that, but the descriptions of the measure construct is available either at the ECQM Resource Center or also the PQM, the new NQF. Any endorsed measures are there. The third place you can look for a lot of these measures is if you look at the Medicaid core sets, they have to publish enough of the measure specification in the Medicaid core sets. You won't see the digital quality measure thing, but you'll get a lot more measure detail about what the measure is and what's expected from core set reporting.
Okay, so
yeah, so there's no easy answer to every question.
Okay, yeah. All right, maybe I'll just email you offline.
Yeah.
So yeah. And obviously, any of the assessments that you're using in your measures, you have already requested.
Yeah, that's what I was talking about earlier. So when we first developed the depression screening measure, we were very explicit. We wanted proms that were like as widely used as possible, and that did not restrict us to only open source instruments, unlike the CMS measures. So we wanted to be inclusive because we wanted to give people credit for doing whatever depression screening they were doing, and that's where we ended up getting most of the acceptance from these instrument owners by only having model in LOINC the total score for that instrument, not the individual question level stuff. So a lot of them were actually happy to have us request those codes for them because they could track the use of their instruments because they had a LOINC code for it now. There were some still holdouts that we could not do. We just could not put in the measure because the tool owner said no.
Wow.
So yeah.
Wow.
So there's
okay.
So there's a nice mix. I mean, I think there's like 22 instruments in the depression screening measure right now. so it's a mix of open source and proprietary instruments. But again, since the measure looks for the total score as an indicator of a screening being performed, it's a bit of a proxy, but I think it's a fair one. And it's fairly inclusive of as many instruments we could model in LINC as that's because that's the current terminology we use.
Yeah.
Okay, well,
Thank you.
yeah,
This is
interesting
really helpful.
conversation.
Yeah.
Yeah.
Hi everyone. A quick question, Nicole. Do we have
Yes.
like a code base for the like a repo, a GitHub repo for this working group?
We do have a repo, although at this point it does not have code in it. Where basically it's sort of the history of the group, so all of our minutes and recording of the meetings are there. And then we're also trying, from like the survey we put out and stuff, linking to the work that other people have been doing. So until we get further along in coming up with our best practices and things, we're aware that people in the community have been working on this. And so trying to kind of centralize our GitHub as a resource so that people can at least see what other groups have been doing. And I did want to say, are you new to the group?
I think so. So maybe I
Okay.
just take 2 minutes, a quick self-introduction. So
yeah, that's what I was going to say.
So
we missed you at the
I'm
beginning, but yeah.
Liu. Also, people call me Jeff. So I work at Dana-Farber Cancer Institute, based in Boston. So I'm a director of data management strategy. So I lead a team of engineers. We help multiple PIs in terms of like the survey data collection, RACAP. We automate the data pipeline and also harmonize the data. And some of the studies observational based and some interventional studies, but we do a lot kind of questionnaires and social determinant of health and cancer survivorship. So that's why I like to learn from this group what's the best practice.
Yeah. Well, happy to have you here. You're at a good point where we're trying to make a lot of decisions, so it's great for that. So yeah, I should probably have it part of the standing part of the minutes. Would you mind doing that, Michelle? Just including the link to the GitHub when you do the minutes for this. So then you can see what we've been up to. And one of the other things I'll share out is the poster and brief that had we gotten to go to Odyssey, we would have shared out. So everybody in the group could see like the summarized survey data and that kind of stuff. And then those the summary tables we did of the survey data are, and by survey, I mean the landscape assessment we did trying to figure out who's doing survey work within Odyssey. So the links to that work, the instruments, what code and stuff they developed for it are all part of that table. And that's in the wiki portion of the GitHub. So everybody should have access to that. So thank you all for joining, especially on a holiday week. I'm glad we were able to at least get one post shutdown meeting in. And like I said, I think we're in a good position to make some firm plans for 2026. So have a great holiday, and I will see you guys in December.
Happy holiday.
Nicole.
Bye.